Hi, welcome to Case of the Day. And guess what? We've managed to get to 100. And I never thought when we started in March that I would be so regular. Anyway, so today is a little bit of a quiz, a T2 dark D1 lesion, and see if you can make the diagnosis. 37-year-old presented with upper dorsal radiating pain to the right. That's the MR. Only a plain scan was done. Expansile lesion. The important thing is that it's kind of T2 dark and slightly crenated margins and a very sharp T1 dark border. What do you think this is? So typically we would think of METs, plasmacytoma, sometimes lymphoma, but you could have a primary bone tumor, in which case it would be most likely giant cell tumor and chordoma. Most of the other tumors would be T2 bright. So a T2 dark tumor has a limited number of etiologies, and that kind of helps us in limiting the differential. PET showed uptake, and that was the only lesion. So unless you have metastasis from unknown primary, which is possible following a biopsy, it is still much less likely than the other possibility. So now we're left with primary bone tumor and plasmacytoma. She was referred for a biopsy. And if you look at the CT, it's completely bland. There's no matrix. There's just there's a crenated margin, and I'll come back to why that is important. That kind of rules out chordoma. So we're left with giant cell tumor and plasmacytoma. I biopsied this 18 gauge Cook needle, 10 millimeter throw. I didn't need a drill or anything, just a little hard push, and I was able to get into the pedicle. And since there was a pedicular lesion, I didn't even bother going into the vertebral body, just biopsied this and came out. And that's the summary for those who are interested in all of this. Transpedicular route, just about 11 minutes, 5 course for histopath, and aspirate for microbiology and cytology. That's the histopath. And for those of you who need some interpretation, these are classic giant cells. And this is an H3.3G34W positive, so a histone positive slide, which basically then tells us that we're dealing with a histone positive giant cell containing lesion, which therefore becomes a classic giant cell tumor of bone. Now, GCT of the spine typically would be T2 intermediate to dark, involves the body and posterior elements. Sometimes you can get fluid levels because of secondary ABC transformation, and this is true of GCTs all over the body, they would be pseudotrabeculated. What's pseudotrabeculated? And this is not a well-known sign. It was described many decades ago, but somehow doesn't get talked about too much. So this is a trabeculated lesion on the radiograph. But on the MR, we don't see trabeculae. Here, of course, it's T2 intermediate and slightly T2 bright. But on the CT, you don't see trabeculae. You may see a couple of septae, but otherwise it's just a very fine crenated margin that gives rise to this trabeculated appearance on the radiograph. So it's a pseudo-trabeculated lesion. And if you look at, I don't have a radiograph here, but the fact that we don't have any trabeculae, but you see this very fine crenated margin. It's a tumor causes this very subtle scalloping along the inner margin of the cortex, and that would give rise to that kind of an appearance. And this, to me, is a reasonably important sign of a giant cell tumor. Plasmacytoma typically wouldn't do this. And here's another giant cell tumor from about 6 or 7 years ago, and I'd biopsied this S1 lesion. And we also see fluid levels because of a secondary ABC transformation. But see how bland the lesion is on CT, and this was a classic giant cell tumor. So a solitary lesion in the 20 to 50 years age group, T2 dark, no trabeculae, but with crenated margins and no matrix, with no other pathology on PET, should raise the suspicion of a vertebral giant cell tumor. And you may ask, what's the big deal? Anyway, you've got to biopsy all of these, and that's true. But the pretest probability helps. And I think in all of these patients, it's a good idea today to get a PET CT done first, because if there were multiple lesions or if there was a primary neoplasm somewhere else, that would completely change things. Also, if you have a larger lesion in the pelvis, and then that typically would suggest that it's either metastases or myeloma, rarely lymphoma, then your approach would be different. The amount of material you would take, whether you'd also take for microbiology, all of those things change. And so before we put a needle inside, the maximum amount of information that we get from non-invasive testing always helps us in not only just getting to an answer, but even planning the biopsy correctly. So while in the end we would biopsy these lesions, there's no harm trying to establish a pretest diagnosis to kind of figure out how best to manage the lesion. That's the panel we're doing a month from now in my WhatsApp channel. Thank you so much for viewing this and being part of this journey. Take care. Thanks. Bye.